Hi everyone. Thanks for joining. We'll be starting in next 5 minutes. Just doing some setup.
Recording in progress.
So we will have an engaging discussion. Right? We will not discuss one way. I have few cases for you. First, I'll just make you a little oriented to the topic, and then we'll go one by one. We will see how to manage each and everything step by step. Okay, so I hope. Just a second, I'm sharing screen and all. So it will be definitely an engaging session. Just give me 5 minutes. We can start. All right, so more than 160 students have joined. And I would love to know more about you guys. Can you please tell me? I think chat section is not on now. I'll just turn on the chat section till the setup is done. We can have a little chat. You can hear from my voice, slightly sick, but that's all right. Okay. Okay. You can now message in the chat section also that so I have one laptop in front of me and this is my iPad. Just because iPad's camera is good, I will be looking sometimes over here and sometimes over here. Okay, so please don't mind about that. Once PPT I start sharing, you will not feel anything about it. Cool. Okay. All right. Hi, everyone. Welcome to the Diabetology webinar. Many of you might be our students already in the ACPD course. I hope you have watched videos which we have covered till now. Yes. I guess, are you able to see me or hear me properly with the screen? Cool. Okay. Okay. Yes. So I think let's start with the top 10 biggest mistakes that we have seen and why most of the patients worsen despite treatment in diabetes. We'll have a discussion about each and every topic, right from introduction to we'll also discuss about the pathophysiology, basics, clinical features, how patient will present, what are the investigation that we have to consider, what are the classification, different classes that when it comes to diabetes we have to consider. We'll discuss everything. Okay, so first let's start with the scale of the problem. So diabetes is not a small entity now. There is not a single condition that diabetes patients are more prone towards. There are so many patients in India also of diabetes. The estimated number in India is around 25 crore people with diabetes and pre-diabetes. Okay, so almost 12 crore people are actually having diabetes in India, and the almost 10 to 15 crore people are with the pre-diabetes. And out of all the diabetic patients, 60% patient have the fatty liver. Okay, so just imagine that how huge is the number. Okay, I mean not only for that diabetic patients, but in entire population, the number of the fatty liver is 1 out of 3, whereas 1 out of 6 Indian is diabetic. So I think this is going to be really important thing when we go into the future, because now there are so many things that are again developing or emerging in treatment of diabetes. But one thing is for sure is there, the services or the treatment modalities are not accessible to the all the different areas in the country. That's what is creating issue, I guess. Okay, so in general, please remember that almost 75% of these people are undiagnosed, and they remain undiagnosed for years. Okay, and 50% end up directly with the complications. So when patients of diabetes come to you, either type 2 diabetes, type 1 diabetes, most of the time type 2 diabetes already have the complications. Because if you know the natural cycle of diabetes, once you have the diabetes, let's say type 2 diabetes is there, what is the pathophysiology for the type 2 diabetes? Yes, anybody? Yes, guys, please let me know. Chat is on, I guess. Chat is not on. Okay, chat box is disabled. Just a second. I'll just turn it on. Hmm. Okay. Sorry. Now you can put message in the chat box. We will put the message in the chat box to make discussion little engaging. Exactly. The insulin resistance is the problem in the type 2 diabetes. So amazing to see all of you. So insulin resistance takes certain amount of time to completely destroy the pancreas. Got it? So after a period of certain days, let's say 7 to 8 years, that is given in the literature itself. I'm not just guessing the number over here. So after 7 to 8 years, pancreas get completely destroyed. Okay, over a period of 7 to 8 years. But till that time, in 7 to 8 years, there's a constant inflammation that is happening in the body because of high blood glucose. And what does that high blood glucose causes? It causes a products called as advanced end glycation products, or AGEs, or advanced glycation end products. Okay, so these AGEs affect all the vascular endothelium. They causes vascular inflammation. They increases the oxidative stress in the your body, basically in the blood vessels or in that local area, causes inflammation. And dhire dhire it causes atherosclerosis, causes vascular complications, and vessels are everywhere, right? In diabetic we have two complications: microvascular, macrovascular. Okay, microvascular में nerves आएगा, retinopathy आएगा, and नेफ्रोपैथी आएगा. मैक्रोवैस्कुलर में आएगा stroke, peripheral vascular disease and coronary artery disease. So big organs we can just remember like that. तो हम लोग डिस्कस करेंगे इसके बारे में. बट दिस इज हाउ द नेचुरल प्रोग्रेशन इज. बट क्या होता है ना, ये जो 7 to 8 years है, टिल दैट टाइम द पैनक्रियाज आर धीरे 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 गेटिंग डिस्ट्रॉयड. योर सिम्टम्स विल नॉट बी दैट अपरेंट और द कॉम्प्लिकेशन विल नॉट बी दैट अपरेंट. और हम लोग लाइटली लेते हैं फिर. कोई नहीं, प्री डायबिटीज है, आई हैव पार्टी, कोई नहीं, यही है बस, कुछ नहीं, डरने की बात नहीं है. बट दैट्स व्हाट मैटर्स. ओके, सो इसलिए since start of the patient's diabetes, you have to even be more cautious, either your doctor or patient's relatives or patient itself, कि this is the start of the journey. Okay, यहाँ से अगर हम लोग पीछे चले जाएंगे तो we will not go anywhere. Okay, maybe we'll just be sit at home and see the complications happen. But if you intervene at this point, then that will create changes. Okay, so that's all about the overall topic, about the overview we can say. Okay, so please remember, India has the highest prevalence in diabetes. I'm using very minor of the Hindis, so please don't worry about it. Okay, so India has the world's highest pre-diabetes. Okay, that's huge. 40 to 20% per year, India is having diabetes and diabetes. Right, right. So here are some micro analysis: India versus West. So there are few things actually. India में ना एक there is a phenotype, or in Indian, or I can say in South Asian people, Indian, Pakistani, Bangladesh, all this South Asian region. There is a thrifty phenotype. Thrifty phenotype मतलब thin fat, as we can see exactly. Thin fat phenotype that is mentioned over here in BMI. Na? So these people have no muscles. Okay, these people have no muscles, but there is a visceral fat, and visceral fat is a very prone for the insulin resistance, and that's why these patients are more prone towards the diabetes, the thrifty phenotype. Okay, as compared to the Western population, they might have muscles, but they have fat everywhere though, and their lifestyle is sedentary. The junk food is there, but still, because they have good muscles, the age of onset of diabetes is later in the Western countries as compared to India. बिकॉज इंडिया में प्रोटीन कोई लेता ही नहीं है, या फिर कोई साउथ ईस्ट रीजन में प्रोटीन्स नहीं है. यू आर नॉट एबल टू हियर मी प्रॉपर्ली, मे बी फ्रॉम इशू फ्रॉम योर साइड, बिकॉज रेस्ट ऑफ देम कैन हियर मी प्रॉपर्ली. Okay, yeah, exactly. So exactly, so the BMI and all those problems are there. Okay, just a second. I'll try to make it little engaging. One sec. Just give me 1 second. I'll just try to make it little engaging. I'm just I'll just share the PPT on my iPad. So I'll be able to write few things over there. So you will find it engaging. Okay.
Okay,
Now
now
I
I
think
think
there's
there's
echo.
echo.
1 second, 1 second. I'm not talking yet. Yeah. Now is it still echoing, guys? Is it okay? The audio is okay now? All right. All right. Okay. Good. 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 Great. So now I have access to write the thing over here, right? Hi. Okay. So we just started with the introduction. We did discuss some things about the epidemiology, that how in India the diabetes is common. Out of every 1 of 6 people in India have the diabetes. Okay, and almost 75% are pre-diabetes. I'll share the recording on YouTube. Don't worry. Okay. So then we started just with the micro analysis, that key why in India people present little earlier, or why in South Asia people present little earlier as compared to the Western population, and that's because of the thin fat phenotype. Okay. So what does this thin fat phenotype means? That means that people in India are like this. Okay. Whereas people in Western countries are like this. Their muscles are good. Okay. The fat might be there, but their muscles are good. Okay. So because of this muscles, the uptake is more. The glucose uptake is more. If you remember the glucose metabolism, when glucose enters into the body from intestine, it goes into the blood. Okay. And as soon as the intestine or the blood senses the glucose, it gives signals to the pancreas to produce the insulin, right? Then insulin causes utilization of the glucose or uptake of the glucose. So it acts on the muscle by GLUT4 to increase the glucose uptake. है ना? अगर if there is no uptake, slides are up very minimal. How is this possible? Why? Why would it happen? Maybe is the text small or the slide is small? I think it must be okay because I regularly take class. Yeah, text I can zoom. No, tell me. Text I can zoom. Okay, we can zoom. All right. So please, yeah, let's go ahead. Yes, so we're discussing about this glucose metabolism, that how once entering into the body, glucose gets utilized by the muscles, glucose get deposited into the liver. Okay, so if you have need of energy, that glucose will be utilized over there. Even the brain utilizes glucose itself. Okay, brain also utilizes glucose. And when we have excess of glucose, it goes into the liver. If insulin is there, then it will cause lipogenesis. Lipogenesis. What does genesis means? Exactly. Genesis means formation. So lipogenesis hoga, and that glucose or that, I don't know guys why slide is small. Maybe you're watching on phone. Maybe that's why you're feeling. Okay. Please. Okay, video is full screen. Yeah, 1 second. I'll just remove the pin. 1 second. Now it's good now. Take it. Okay. All right. So lipogenesis happens in presence of insulin, and then most of the glucose gets utilized. Okay, but gradually, as insulin resistance is there, all this glucose will increase in the blood, causes complication with the help of AGEs. Now, in if you have good amount of muscles, which is seen in Western population, these muscles are there, right? So these muscles utilize glucose as much as they can, and that's why the diabetes presentation is less late in case of Western population. All right. So that's why we see the age of onset in Indian subcontinent is around 30s and Western it is 40s. All right. BMI, now talking about the BMI, obviously lower BMI people can also have diabetes in India. Triglyceride and HDL are more abnormal and insulin resistance are kind of higher in Indian subcontinent because of the visceral fat. And why it matters? Because it leads to earlier beta cell burnout. And that's why the diabetes appear faster. So what is this beta cell burnout means? That means whenever your body is giving insulin resistance, the signal goes to the pancreas that insulin is not getting produced. So so pancreas try to secrete more and more and more and more insulin, and that's why the beta cell burnout occurs little earlier in the Indian people. Okay, that's why the overall that's the critical differences when we see than the Western countries. That's why Indian people have the earlier presentation of the diabetes. Okay, it's not some pharmacy scam, or it's not because of pharma people earn more money in India, not because of that. If someone has a good muscle bulk, okay, if someone's family history has a good muscle bulk, and they all work out regularly, obviously the diabetes presentation will be kind of late in these patients. Okay, all right. So that's the second point, that is the microanalysis. Now here are the 5 reasons for misdiagnosis and treatment. So I'll zoom it, no worries, nothing to worry, I know it's very small. So first is about the wrong assumptions. कि यहाँ पे सबको everybody feels in India that if patient is young, it has to be type 1, and if adult is there, type 2 is there. Okay. And if patient is thin, that means diabetes would not be there. Okay. So these are the few misconceptions or assumptions that people do. I'll tell you why. So even type 2 diabetes patients can be lean, as we discussed. Okay. Even type 2 can be lean, and even type 1 can be fat. Okay, we will discuss that in due course. Then there are outdated, so HbA1c also, people feel that HbA1c is absolute truth for managing diabetes. Can anybody tell me? Yeah, exactly, Lada and Modi. I have added questions for that. That's why I didn't go in detail. All right, so HbA1c, first tell me, when will it be high in case of, or like in which cases it can be pseudo high, HbA1c? Does anybody know? What is HbA1c first of all? Okay. Exactly. It will be falsely high in case of anemia. Why? Why? Anybody can tell why? So what happens in anemias? The RBCs are less. The RBCs are less. So what does, sorry guys. 1 second. Sharing screen again. Yeah. So we were discussing about in anemia what happens. So in anemia, RBCs are less. So because of that, the duration. So because of that, the duration of the RBC for the time that they are alive is kind of longer than the normal public. Okay. And that's why you see that this patient has falsely high HbA1c. Can it tell me when it will be falsely low? falsely low. Obviously, if anemia has higher RBC lifespan, your HbA1c can be falsely high. Which RBC does not have higher lifespan? So that is hemolytic anemia. Exactly. In case of hemolytic anemia, the HbA1c will be falsely low. Okay, so we use one test in this case. What is that? We used one case, a test, special test in this case. Anybody knows that? Fructosamine. Okay, not TIR. We test fructosamine. Okay, I'll explain later. Yes. So the second set of mistake is people still believe in India that sulfonylureas only will help. Metformin sulfonylurea उसके ऊपर जाते नहीं है. Okay, people feel little scared to go ahead from metformin and sulfonylureas. That's also one treatment mistake. Then they don't use phenotype based treatment. So what does this phenotype means? Phenotype means presentation. If patient is obese plus diabetes, go for GLP-1. If patient is having cardiovascular disease and diabetes, go for SGLT2 inhibitors, go for GLP-1 suppressors. Okay, so that's how. Based on the phenotype, you have to manage the patients. Okay, then over dependence on fasting glucose. So this is also one more fact. So can anybody tell me, in patients of diabetes, does fasting glucose impaired first or postprandial? Very nice. Good. Proud of you all. So why it happens? Do you know? Do you know why it happens? Anybody? How exactly? Yeah, yeah. Somebody mentioned loss of first phase. Very nice. Okay. Very nice. Okay. So because of loss of first phase, so insulin secretion is always occurring in the two phases. Okay. First phase and second phase. So in first phase, what happens? Your pancreas has some sort of stored insulin. Let's say vesicles means there is an insulin stored. So when you eat something, this first phase will be activated in first few hours. Okay, sorry, not hours, minutes. Okay, 1 to 2 minutes, and then the insulin is produced, and that will control your postprandial sugars. But in patients of type 1 or type 2 diabetes, or in patients of pre-diabetes, this first phase is lost. That's why in patients of diabetes, first postprandial sugar will get abnormal and not the fasting. Fasting is actually used in case of metabolic syndrome. Do you know 4 things that is checked in the metabolic syndrome? Fasting blood sugar, blood pressure, dyslipidemia, waist circumference. Okay, right? So these 4 things are measured in the metabolic syndrome. But if you be over dependent on fasting glucose, you might miss the pre-diabetes and important diabetes in your patients. That's also one more mistake. Don't worry, we will see entire cases. I'm just explaining the scenarios. Then ignoring phenotype, we already discussed this. Indian visceral obesity patients, PCOS metabolic syndrome. Okay, patients' testosterone will be high. So recently I saw this one patient. Her testosterone was high. Okay, and they were planning to get pregnant, and because of so many things, they were not be able to. I mean, she had the subclinical hypothyroidism also, so we had to manage that with the thyroxine. But yes, so these are the few things based on the phenotype you have to manage. Okay, so metformin also I started for them. Anyways, we'll discuss this. Right, then body suspicion neglect. So whenever you have family history of diabetes, more than 2 generation, because that will be considered as MODY, that is maturity onset diabetes in year. Usually diabetes is considered as polygenic. Matlab, multiple genes are involved. But if only single gene is involved, that will be called as, yes, if multiple gene is exact, no, not MODY. If multiple gene involved, that will be called as polygenic. If single gene is called a monogenic. Exactly. So MODY is a type of monogenic diabetes. Okay. Monogenic diabetes, and it has what type of inheritance? Autosomal dominant. Okay. So that's very important point that we should not miss. We'll discuss the case on that. We will learn more and more. Then in India, there is, and I mean, majority physicians don't have structured monitoring. There is no plan. Patient is coming, you are just managing sugar, patient is going home. That doesn't work like that. Patients coming to you, you have to have entire record that when was the last time I checked the ACR for this patient. ACR is albumin creat ratio. That will give me idea about the diabetic nephropathy. So all these things has to be checked. Okay. So if patient is having type 2 diabetes, it has to be checked at the time of diagnosis. If type 1 diabetes is there, then based on the age we screen. Okay. If age is more than 30, then screen at that point. If age is less, around 20, Then maybe check after 5 years. Okay. So this is how the rough protocol is there. So no ACR, no retinal check, no foot exam. Okay, you have to tell about the patient about the foot exam. Then triglyceride digital tracking, nothing is there, and patients suffer. And wrong focus. People focus more and more on the sugar. Okay, and too little on the insulin resistance. This is a very important thing that you should remember in managing diabetes. Okay, focus more and more on the sugar, not the insulin resistance. Then people just think that diabetes is just a sugar disease. But no, it's a metabolic condition. It has vascular complication and neurological complication. So please remember, in diabetes, you are not treating number of the glucose. You are treating a disease. It's a disease of the multiple systems and you are managing that. So all these things has to be taken in mind. Okay. Right. So what we will cover today? We will cover pathophysiology, basics. I've already told you. Okay. Then we will cover 10 landmark cases, diagnostic mistakes that happen, treatment mistakes. In that 10 cases, we'll discuss nutritional exercise mistakes, what people do, what are the advices that should be given to the patient, unknown complications, correct protocols, and question and answer. Okay. About the ACBD structure, I'll just explain. All right. So diabetes is not a sugar problem. It's a multiple problems that are combined together. All right. So here is also one more thing about the diabetes, that apart from sugar, what exactly it can cause. So in the retina, it can cause microaneurysm, kidney में microalbuminuria, nerves में neuropathy, heart में LV remodeling, and liver में fatty liver. Okay. So these are the problems that happen in diabetes. And as I already mentioned, most patient present late, most doctor treat numbers, wrong categorization, wrong drug, wrong outcome will happen, and complication often subclinical for 5 to 8 years. Okay. So please remember this. Okay. I'll explain diet wala questions also. Please don't worry. Okay. So India is the perfect storm for the early diabetes because of all these numbers. Okay. So now let's quickly see the pathophysiology of the diabetes. So this is a flow chart. So first, because your body has more amount of fat, okay, more amount of fat is there. Adipose tissues has fat, okay. Then even the hepatic resistance is there. Okay, hepatic fat causes hepatic resistance of insulin. So what happens because of this, all these tissues? Insulin doesn't work. Okay, insulin doesn't work. So I'll just explain you in real quick way. Okay, to act on the body. Suppose, yeah, suppose this is the blood. Okay, this is the one vessel, let's say, and this is the gut. Okay, this is the gut. In gut, the glucose is there, glucose is there, glucose is there. And now this glucose wants to enter into the your blood vessel. This is what? Sorry for this frequent issues. This is your blood vessels, okay? And this is glucose molecule. It wants to come inside the blood vessel, or it wants to come inside the muscle, let's say. So to come inside, we need insulin's permission. Okay, so this is called as insulin receptor. Okay, this is insulin receptor. So what will happen in your, this is your, I'll just change. This is the gut, let's say, or let's say the muscle. 1 second. This is the muscle uptake, let's say, and this is the blood vessel. Okay, so insulin from here will come on this receptor. This insulin will attach over here, and that will cause multiple changes. Two pathways are there. Okay, AMPK pathways. So these pathways will activate the insulin uptake in the cell, and then insulin will allow the receptors. We know we have multiple GLUT receptors are there, also called as glucose uptake receptors. So GLUT will get activated. Let's say this is muscle, so GLUT4 will get activated, which is insulin dependent. And then this glucose enters into the cell. Okay, this glucose will now enter into the muscle, and that utilization will happen. Now what happens? This insulin receptor, I told, insulin receptor, okay, it has alpha and beta chain. Don't want to go in complications. Alpha and beta, 2 alpha, 2 beta. This is, let's say, extracellular, and this is intracellular. So what happens at multiple sites? If there is extracellular problem, there will be insulin resistance. If there is an intracellular problem, there will be insulin resistance. If there is a mitochondrial problem, Okay, in case of monogenic, there will be insulin resistance. So because of multiple factors, and if there is a hyperinsulinemia, what does this hyperinsulinemia means? Hyperinsulinemia means insulin is high. Okay, why insulin is high? Because glucose is high. Why glucose is high? Because person is not working. Person is not working, sitting at one place, just eating, not doing any activity. So glucose will be high, insulin will be high because of that. Now, because of this high insulin, this insulin receptor, okay, which I shown over here, this insulin receptor, this gets down regulated. What does down regulate means? It gets deactivated. It gets deactivated. And because of that, patient's insulin will be high. Because of that, patient's glucose will be high. And that is what insulin resistance is called as. Okay. So it all starts with insulin resistance. Now then what will happen? Then because of insulin resistance, your pancreas feels that insulin is not working properly or insulin is low. So it keeps on producing the insulin. And that leads to beta cells functions or beta cells decline. Okay. So that leads to diabetes. Now this is one more concept, that what is the incretin defect. Okay, so incretin is also, incretin also works on the beta cell. So what is incretin? It's a very important and very, update. Multiple drugs are also working on this effect. So when food enters into your gut senses glucose and it tells your body, your pancreas to produce hormones. Okay, so it tells beta cells to produce insulin. It tells alpha cells to produce glucagon. Okay, so it works in that way, so that counter regulation and all work together. Okay, so what will happen if person eats? So normally insulin should get produced. Okay, but if this incretin defect is there, patients alpha cells get activated and glucagon is produced. And you know what is the function of glucagon? Glucagon increases more and more glucose. And gradually, because there's more glucose and insulin is not there, there is called as glycolipotoxicity. Okay, glycolipotoxicity. Because of this glucose, there is a lipid toxicity that happen in multiple cells and the visceral fats. And because of that, the insulin resistance increases more and more. Now, at the same time, as I said that because of insulin resistance in the liver also, liver has a function of storing glucose. But if liver has insulin resistance, it will produce more and more glucose. It does not store glucose. Why? Because the receptors are not working properly. So it causes gluconeogenesis. That is glucose overproduction and increases the blood sugar, causing complication. Similarly, kidneys, by the help of SGLT2 receptor, right? If you remember, SGLT1 receptor is present in the gut, SGLT2 receptor present in the kidney. So in patients of diabetes, this SGLT2 receptors work more and more and more and more. And because of that, kidneys will also feel the body's overall glucose increases. So we have one drug which inhibits this SGLT2 inhibitors. Can you tell the name of this drugs which inhibits this SGLT2 action in patients of diabetes? And because of this, patient will obviously, when we inhibit this, the exactly gliflozins. Okay, it is called as gliflozins. Okay, very important. Also, in patients of diabetes, the brain appetite dysregulation occurs. Brain appetite dysregulation means when I eat something, my brain tells my stomach, you're full now. So you feel full, you don't eat anything. And it is maximum with the proteins, not with the carbs. If you eat carbs, you keep on eating the carbs. But if you eat protein, some small quantity of protein will feel full earlier. And lastly, because of increase in glucose constantly in blood, there is inflammation and oxidative stress that affects or damages the vascular endothelium. Okay, it affects the vessels, and because of this, complication occurs. Okay, so this is the full mechanism that we discussed. So main problem is insulin resistance, as we discussed. All right. So this is all whatever I have given over here. Now here is one more concept that is called as the 10-year mistake, which I already told you that what happens during this year is beta cells functions drop to 50% by diagnosis. Okay, so whenever patient is presenting with the diabetes, already the 50% of the function has already gone. So you have to know about that. Okay, diabetes begins 10 years before a diagnosis, and you have to know this. That's why you have to ask patient to take it seriously. It's not only your job. Okay, you have to make assure, you have to counsel the patient that it has not started today. It has not diagnosed today. You have been diabetic since last 10 years. Now, then all complications have already occurred in your body. Okay. And I mean, don't scare them, but tell them that this is the few last things that you have to take care in your life. Otherwise, it might end really not well. Okay. So that's how the counseling should be, that you have to know this 10-year mistake. Okay. So because of this, post-meal glucose rises first, which we discussed, fasting glucose rises last, and complications start silently. Okay. And why patient present list? So patient small fiber neuropathy because it does not have any symptoms. Retina changes through painless, and albumin creatinine ratio rising doesn't change creatinine, so they don't know. They will only feel frothy urine because of proteinuria, even if it's like really heavy. But most of the time it will not be heavy also. And fatty liver is obviously asymptomatic. So patient will present later. Okay. Right. So now let's start with the cases. Very, very important cases we have. So first question we have, can you see the screen properly or shall I zoom it a bit? So you read the question first. So we have a 34-year-old male. Now we'll discuss the case. On the best of the case, we'll discuss. Okay. Sorry. 34-year male, BMI is 23, was started on metformin and DPP-4 inhibitor. And I will tell you what is the example of DPP-4 inhibitors. Okay. Gliptins. Okay, correct. Okay. Sitagliptin, vildagliptin. Okay, yes. So 34-year-old male, BMI 23, has started on metformin, DPP-4 inhibitor for newly detected diabetes. After 3 months, HbA1c worsens from 8.6 to 10.9, not getting better with the OHA. Okay, he's just 23. Fasting C-peptide is 0.4. Fasting C-peptide is 0.4. So what could be the diagnosis? See, HbA1c is worsened in this patient and fasting C-peptide is just 0.4. What should be the diagnosis? In patients of type 2 diabetes, he should have responded well. So that must not be the diagnosis, right? Is it ketosis prone diabetes, that is diabetic ketoacidosis? Is it that? No. Why? Because C-peptide is not that low. Is it MODY? Is it MODY? MODY they would have given the family history, autosomal dominant, and patient responses well to sulfonylureas in MODY. Okay. Is it stress hyperglycemia? No. Why would HbA1c be that high in stress hyperglycemia? And that's why the answer is LADA. That is latent autoimmune diabetes. Okay. So in this patient are lean, but they have type 1 diabetes. It's an autoimmune condition. Okay. It's an autoimmune condition. Okay. It's an autoimmune condition, but it causes damage slowly. Okay. It affects pancreas slowly. Okay. Pancreas is affected a little slowly as compared to type 1 diabetes. And that's why you might feel that in earlier phase, OHs are working, but in later phase, OH does not work. Okay. So that's one question I had recently posted also, the real life posted also. Okay. So I'll explain that. The correct answer for that question was LADA. Why? Because the patient was lean adult. There was OAD failure, that is oral anti-diabetic failure was there. Okay. Low C-peptide were there, sorry. Okay. Sharp rise in sugars were seen because beta cells of pancreas are not getting destroyed and autoimmune pattern is there. The only thing, low C-peptide is here also, but how we differentiate between type 1 then? So in type 1, make sure that OAD never work. Here, OAD is working or oral anti-diabetic drugs are working in early phase. Okay, so that's the only difference, that how we differentiate. C-peptide, here it is low. Okay, normal to low it can be. Okay, in case of LADA, but it will be low in case of type 1 diabetes. Okay, and here it can be normal to low. Okay, so that is about the LADA. Okay, so we already discussed LADA it will be an autoimmune beta cell destruction. So what are the autoantibodies? GAP65, IA2, ZNT8. You have to check for these antibodies in your patients. Okay, C-peptide drops gradually, as I mentioned, and looks like type 2. And oral medication, we have to treat with insulin. This patient has to be treated with insulin. Start early insulin. Why? I'll tell you why. Because the pancreas are already dying. And if you're giving OHA or if you're giving secretagogues, what do we say? Secretagogues means they stimulate beta cells like sulfonylureas. So these beta cell destruction will occur faster and faster and faster. That means you are squeezing already dying pancreas. Okay, pancreas is already dying, and you're squeezing that pancreas and you're completely destroying pancreas for that person. So because of that, better to introduce insulin early in this patient. So that's the theory behind it. Okay, sulfonylureas accelerate the beta cell death. That's the point I just explained. Okay, right. So where people go wrong in this patient is mislabel every adult patient as type 2 diabetes, not checking antibodies. Delayed insulin causes glucotoxicity. They don't know this. Keep on increasing OADs without thinking of insulin. Just don't listen to patients when it comes to their benefit. This is a very important thing that my senior used to tell us, that you might have heard about his name, Dr. Shashank Doshi. He's a diabetologist, Padma Shri awardee, and I mean, like, he's my mentor. So he used to always just say, "Ki, don't shy in front of patient or don't listen to your patients when it comes for their betterment. Okay, you don't just keep increasing OADs. Just counsel them. OADs will not work, and you're gonna make situation even worse. Start taking insulin, and I'm not getting any cut. Take anywhere. Okay, so that thing also you have to explain, because as a physician, people always are skeptical that is he doing cut practice or what. So always be very confident about these things. Okay, then people don't measure C-peptide levels. Okay, C-peptide level can be normal initially, but yeah, the other give is just an idea. If you again 3 months after check the C-peptide, it will be low then, right? Then blame patient for non-compliance. Okay, just tell the patient ki you are not taking OHs and that's why your HbA1c is increasing. You can't blame them unless you are very sure. Okay, because in early phase, listening to some babas and all, people feel ki no need of medications. Okay, it's just a scam, but it's not like that. Okay, so red flags of LADA: age less than 45, BMI less than 25, OAD failure in 3 to 6 months, family history of autoimmune disease, and low C-peptides. Because it's autoimmune condition, it will have association with the thyroid condition, vitiligo. So all this you have to check. Okay, so correct treatment in this patient: check antibiotics, start early basal insulin. What does basal insulin means? Glargine. Okay, Antus. I'll not be taking a brand name, but Glargine. The example, okay, the one of the example is Lantus. Start basal insulin. Avoid sulfonylureas and preserve beta cell functions. Okay, I hope you got it. So next question is about this very important case. Look at this case. A 28-year-old woman is there. HbA1c is 9, but she has hemoglobin of 7.8 gram per deciliter. Ferritin is low. Fasting glucose is 96. Postprandial is 128. Just tell me that how will you manage this patient? Option number A, will start metformin. Option number B, check for fructosamine. Option number C, will do blood transfusion or IV iron. Or let's say IV iron first, and then fifth is insulin. How will you manage? Exactly. Why to give insulin, guys? This patient is anemic, and I already told, whenever there is the anemia, RBC lifespan increases. Why? It's a body's mechanism to survive or to give more iron to the blood or to the organs. It's a body's mechanism to replenish the iron. That increases its lifespan of the RBCs, and because of that, your HbA1c. What is HbA1c? HbA1c is glycated hemoglobin. It glycates the beta part of the hemoglobin, Hb, and it depends on the RBC lifespan. What is normal RBC lifespan? Can you tell me how many days? 90 to 120 days. Okay, 90 to 120 days. Not like just in medicine, always give range. 90 to 120 days. But when it comes to some answers, don't give range. Okay. So if you ask the normal temperature, we can't say 35 to 37. Okay, 37. That's the normal temperature. But in some things, you have to give. Okay, so 90 to 120 days, they say. So these are roughly 3 to 4 months. So RBC's lifespan is that 3 to 4 months. So for entire 3 to 4 months, how much glucose is attached to the beta unit of the hemoglobin, that or glycated to that beta part of the hemoglobin, that gives me this HbA1c or 3 months average blood sugar. Now, if my RBC is living 5 months, obviously more glucose will get attached to the this or more glycation will happen. So my HbA1c will be falsely high. And similarly, if I'm having hemolytic anemia or hemoglobinopathies, My RBC will get destroyed very quickly. Let's say it's a sickle cell anemia, thalassemia, let's say. My RBC will get destroyed quickly by the spleen. And then my HbA1c will be falsely low. Okay. So HbA1c is not a gold standard. Okay. And therefore, and also one more thing clearly that tells us over here is fasting and postprandial are normal. If they would have been high, and somebody asked, if they would have been high, then it would have been diabetes. But again, I would have confirmed with the fructosamine. Okay. Just to be little sure. So these were the options which we just had over here. Okay, so the correct diagnosis is B, that is check fructosamine. Okay, so why? As I already explained all these things, iron deficiency anemia, RBC lifespan increases. Longer exposure to glucose, falsely high HbA1c. HbA1c does not reflect the real glucose. Okay, similar false finding can be happening in thalassemia, hemoglobinopathy, CKD pregnancy. So better we use the fructosamine and glycated albumin. Fructosamine is simple, just like that. HbA1c only. We have to check it. It checks the average blood sugar for 2 to 3 weeks. Okay, 2 to 3 weeks. Okay. So what were the mistakes in this patient? Starting insulin based on HbA1c alone, ignoring FBS, PPBS, and SMBG. SMBG means self-monitoring of blood glucose. Okay. Then misdiagnosis, diabetes in anemia, and not knowing HbA1c limitation. So these were the mistakes that happened over there. Okay. So these are the cases where HbA1c is unreliable, and we therefore check the fructosamine, which has 2 to 3 week control. It checks. Okay. Glycotrol albumin. So fructosamine is checked because fructosamine does not vary. Okay, it's also one of the protein that is present in your blood which attaches to the glucose. Okay, but it does not vary with the RBC. That's why we check that. Simple, logical. Okay, glycated albumin, CGM, and SMBH are the options in this case. Okay, now here we go. In the next case, we have 45-year-old man, BMI is 29, as newly diagnosed diabetes, doctor starts the glimepiride first. Okay, BMI is 29, that means he's obese. In 3 months, after starting glimepiride, his weight is more increased by 4 kg. That's 2 hypoglycemia episode, but HbA1c has gone from 8.2 to 8.1, which is practically no improvement. So, what will be the diagnosis or what will be the answer? Option number A, he needs insulin. Option number B, sulfonylureas is not the first line in diabetes. Okay. Option number C, glimepiride dose is low. Option number D, he needs DPP4 only. And option number 5 is he had MODY. What do you think, guys? Yes, please. Come on. I want more people to engage in this. What do you think would be the answer? Some people will right away in clinical practice start insulin. I'm 100% sure. Even you have must done this. Patient is not responding to sulfonylureas, metformin, start insulin right up. We can't. Okay. And the thing is given is Indian phenotype. So insulin resistance has to be there. Okay. Sulfonylureas is the first line, not a first line for obese higher phenotype. Okay. That can be answered. Glimepiride dose is low. So again, this is also very common. People directly increase the glimepiride dose, but that doesn't work like that. He needs the PP4 only. No. Okay. He has MODY. No. Okay. So the answer will be sulfonylureas is not the first line for the insulin resistance. See, you have to understand the pathophysiology. As per the Indian phenotype, patient has the high insulin resistance. And if you give sulfonylureas, that will cause beta, that will overstimulate beta cells. And that will again cause the weight gain. How? Beta cells will cause more and more and more and more insulin release. And that will cause weight gain because of insulin is a lipogenesis. Insulin called lipogenesis. It is not lipolytic. It will cause lipogenesis. It will cause more and more fat deposition in the adipose tissues, and that will lead to weight gain. Okay. So, as such, sulfonylureas does not have any impact on the insulin resistance. Even if you give sulfonylureas, the hypoglycemia risk will increase. Okay, gradually. Okay, so this is all important things that we have to know. So, what are the better first line options if patient is obese? Anybody? In obese patient, what drugs you will think of first to start? Come on. Somebody mentioned semaglutide. Why don't you go for simple things first? Start with metformin. This patient was not on metformin, right? So better to start with metformin, SGLT2 inhibitor, and then gradually we have to start. Okay, metformin, SGLT2 inhibitors will be helpful. Okay, right. Let's go to the next slide now. The same answer will discuss. Okay, so the correct answer was B. Why? It's because there is no impact on insulin resistance. In fact, there is a worsening of the hypoglycemia that's occurring because of this. Okay, we discuss all these points. So metformin, SGLT2 inhibitors, and GLP-1 are the preferred options. Okay, so what mistake happened? Giving sulfonylureas as the first line, treating fasting value only, not assessing the phenotype of the person. Okay, this is very important, and overlooking ASCVD, CKD, and heart failure profile. Okay, so these were the mistakes that happened in this patient. All right. So always remember, if patient is obese plus insulin resistance is there, go for the metformin first. Okay. If thin patient is there with same type of phenotype, check for the LADA. If young patient is there, rule out the MODY. And if heart failure CKD is there, start with SGLT2 inhibitors. If the CVD risk is there, cardiovascular disease, then GLP-1R. Okay. So I'll just zoom. Obese IR, metformin, thin check LADA, heart failure, HLD2, ASCVD, GLP-1RA, and young rule out MODY. Okay, so as you know, we have our ACPD course. So there I have told exactly that how to start treatment and all. The investigation module is uploaded. Treatment module is left. So I'll be uploading the treatment module also soon. Okay, but this is how the cases are. Okay, this is how you have to think of scenarios. Now let's go to the case 4. This case 4 is very important. Please answer this one. Okay, we'll just see practical information from that. Okay, so a diabetic patient performs high intensity works out only. Okay, he's only performing high intensity workouts. Post exercise sugar spike is from 140 to 240 milligram per deciliter. So what happened in this patient? Anybody? Option number 1, meter error. Then option number 2, cortisol plus catecholamine surge. Option number C, insulin overdose. Option number 4, liver disease or incorrect carb intake. What do you think? Exactly. Exactly. Very good and easy. Actually, the question I've kept easy only. So obviously, this patient will have really sorry. So this patient has the catecholamine surge. Okay, catecholamine surge after exercise happens. And what mistake he has done? So as a dietitian, as a doctor, it's your job to advise the patient about the exercise also. While telling them, just don't tell, gym mein jao exercise karo. Just tell them, you are not any random person. You are a doctor. So tell them to do aerobic exercises, and you can do little cardio also. If you have heart issues, better not do high intensity workouts. Why? If you do this high intensity workout, there can be catecholamine surge, which can cause increase in the heart rate, which can worsen your situation. Okay, so बहुत एक्साइटेड हो जाते हैं पेशेंट्स, डायबिटीज डायग्नोस हो गया, जिम लगा दिया, HIIT करो, और जिम ट्रेनर मोस्ट ऑफ द टाइम्स डोंट नो ना अंडरलाइन सिचुएशन क्या है. इंडिया में कहाँ सब रिव्यू होता है पहले पूरा कि द फर्स्ट एक्सरसाइज प्लान एंड ऑल, इट डजंट हैपन राइट. दे अपना भागो इधर से उधर, और अंकल लोग अपने जिम में तो जिम में इन द gardens also you might have seen. There are few videos on the social media, right? एक तो मेरे मेरे अंकल देखा था, एक तो उनका एक्सरसाइज बहुत ही फनी था. ओके, बॉल ऐसे ले रहे थे वो, ऐसे बॉल ले रहे थे एक दूसरे से. एक बड़ा बॉल था, they used to do. अरे क्या कर रहे हो अंकल? So you have to advise it. Okay, as a doctor, it's your job. And that's why people are laughing at the doctors nowadays कि डॉक्टर को न्यूट्रिशन एक्सरसाइज के बारे में कुछ पढ़ाई नहीं जाता. पढ़ाया जाता है यार, तुम लोग अप्लाई नहीं कर रहे हो बस. Okay, that's the problem. Okay, so make sure ask the patient to not only high intensity exercise, ask them to don't believe that more intensity means better or more strength. No, diabetes patient has to be more agile. They have to walk more. They have to, if possible, they can run also a bit or cycle. So aerobic exercises they have to do. This HIIT, it's kind of they might get short of the breath also in this, okay, and which is really dangerous. Also, one more thing, diabetic patient exercise in the fasting state. Okay, it should not happen. So before every exercise, make sure that you are giving the carbs, certain amount of carb to this person. Okay, why? Because the carbs will be get utilized. Okay, so 100 grams it is supposed to be given. Okay, so I'll give you exact number. So that has to be done, and they should not exercise in the fasting state. And while exercising, they should not do CGM monitoring. ले लिया है तो करते रहो. Okay, so all these things that should be there. Okay, right. So the correct answer was catecholamine surge during HIIT, that is high intensity exercise. Adrenaline will increase, liver dumps glucose causing gluconeogenesis, cortisol rises. Okay, then muscle temporarily insulin resistant. Okay. So, case 4 explanation. We did already said the mistake. Don't only do high intensity, believe more intensity, not mixing aerobic resistance, exercise and fasting, and no CG monitoring. Okay. So, you have to do best for sugar control is 15-minute walk after meals and moderate aerobic exercises. Okay. And this is how the ideal exercise you have to give to the patient. 150-minute week per aerobic, 2 interval training, 10 to 15-minute post-meal walk, and flexibility and the core strengthening. Okay, so this all you have to tell the patient. Okay, and best for sugar control is 15-minute walk after meals. How? Why it is important? So there are several studies. So that study showed that once you have a glucose in your body after you have a meal, if you walk for 15 minutes, the muscles get activated, the leg muscles get activated, and they want more glucose. So GLUT4 related uptake increases in the muscle, and that minimizes your glucose spike. And do you know why the glucose spiking minimization is important? Because if there is a glucose spike, the pancreas will work more, the insulin will be produced more, and already pancreas are dying. So if you are causing this glucose spike, the pancreas will die faster. That's why in patients of diabetes, not even patient in diabetes, in any patient, you should be mindful for your glucose spikes. Either you're eating some cookies, okay? So 100 calorie of apple and 100 calorie of cookie. में क्या difference है? What will you prefer? So when I asked one of this patient to my batch, so they said, sir, mood का difference है. मैंने बोला, एप्पल का तो मूड कभी रहता ही नहीं है ना. What is the difference? Exactly. That apple has natural sugars. It has high fiber. The glycemic index is low. Whereas cookie has the refined sugar. So refined sugar is the glucose spike फटक से होगा. Glucose spikes फटक से होगा तो क्या होगा? And because of that glucose spike, you will have more insulin production and pancreas will have to work over time. So that's why Apple is better. Okay, not Samsung. All right. Okay, now coming to the nutritional disaster. One more mistake. Okay, so 40-year-old man has come to us. He's trying to reverse diabetes. Okay, cut all carbs. This is very classical case. On social media, so-called influencers are doing this. The health influencers. Okay, fasting and all this stuff. It's a good to certain extent, but has to be done under monitoring. Okay. So 40-year-old man trying to reverse diabetes. Okay. Once he will reverse, he will let us know all that is this possible or not. Okay. So I've seen one case from, I don't know, it's from Kerala or somewhere. So this guy was there, a young guy. You know what? He he went on 21-day crash diet. He just took glucose and now, sadly, he is just taking glucose in the heaven. Okay, this is the thing. If you just listen to the social media influencers, this is not done. Okay, because they don't know the physiology or pathophysiology. All right. So we have a 40-year-old man reversing diabetes. I don't know why my pencil is not working. Just a second. Now it will work. Okay, yeah. So we have a 40-year-old man trying to reverse diabetes, cuts all carbs from his diet. After 6 weeks, constipation, fatty liver, worsen, hair fall, low energy. All these things will happen. What is the cause for this? Can anybody tell me without seeing options? Is this because of excess protein, extreme keto diet, fiber deficiency, vitamin B12 deficiency, low insulin, or thyroid disorder? Yes. What are the symptoms? Constipation. क्यों होगा? ऑप्शन में दिया है देखो. एक्सट्रीम कीटो डाइट, फाइबर डिफिशियंसी, विटामिन डी, क्या है ऑप्शन? क्या लग रहा है? व्हाट डू यू थिंक? प्रोटीन लॉस. एग्जैक्टली, प्रोटीन लॉस इज देयर. एक्सेस प्रोटीन नहीं है, प्रोटीन लॉस है, एक्सट्रीम कीटो डाइट है. Extreme keto diet and fiber loss. Okay, so the option is B is the correct answer. Okay, so see, cutting carbs removes the essential soluble and insoluble fiber. तो आपके पास कोई डायबिटिक पेशेंट आता है, just don't tell them कि stop eating rice, stop eating chapatis. That is the important source of carbs. And still, if you have diabetes, 50% of the nutrition has to come from the carbs. So you can't just tell them, you need to cut down the carbs. Just take protein, just eat eggs, avocado, etc. Okay, so this is the fact. With the carbs, you will get the soluble, insoluble fibers. If you stop the carbs completely, your gut microbiome will get disrupted. And because of that, you will have constipation and multiple symptoms. Now, if the fibers are not there, your fats will increase, LDL will rise, fat liver will worsen. And similarly, because there is less carbs, less fat, the keto adaptation will occur or ketone bodies will get produced. Okay. And even the constipation is very common in this patient. Okay. So please remember, carb is not enemy, that we have to change that mindset. Still, we require 40 to 50% of the carbs in the diet. 20% should be protein, rest of the fat and fibers. Okay. Yes. So make sure you don't follow influencers for diet and diabetes advice. Okay. Unless they are well qualified. Okay. Make sure that you know the degrees. I think जैसे लेबल पड़ेगा इंडिया कैंपेन आया था ना, वैसे एक डिग्री पड़ेगा इंडिया कैंपेन आना चाहिए. We should work for that. Okay. So after today class, I want you to share stories. डिग्री पड़ेगा इंडिया. Okay. बिकॉज कोई भी आके आजकल ये देके जाता है सोशल मीडिया में. मैं देखता हूँ कभी कभी यार, मुझे आता है कि नहीं इनका नॉलेज देख के. समटाइम्स आई गेट लिटिल फैसिनेटेड कि यार इतना कैसे पढ़ाई कर लिया इन्हें एक रील के लिए. बट द इशू इज दे ओनली हैव नॉलेज अप टू वन रील. ओके, दैट्स द प्रॉब्लम. दे डोंट नो द एंटायर पिक्चर. कॉन्फिडेंस इज देयर. Okay, I'm not against any social media creator or anything. If someone is working really hard, has a qualifications, then that's good. Then that's good. But if someone is just, doing time pass and discussing with the friends or learning from the social media, WhatsApp University, then it's a problem. Okay. So please make sure your patient should also be advised for this also. Okay. So what went wrong? Carbohydrates are enemy. Mindset we have to change. Following influencer diets have added that point. No structured nutritional plan. Removing dal and fruits completely. Okay. So this is also a wrong step. Okay, right. So correct explanation should be, this is how the diet should be. Please take a snapshot and remember this throughout entire life. 40 to 50% still should be the carbs, complex carbs. Carbs मतलब उनको कोका कोला मत पीने के लिए बोलना, उसमें भी carbs है. That doesn't works. We want complex carb from the fruit vegetables. Okay. Then 25 to 30%. Okay. Then 25 to 30% of the protein should be taken. 25 to 30% of the healthy fats and fibers around 25 to 40 grams. Okay, make sure. मुझे लगता नहीं है इतना बैलेंस डाइट अपना भी होगा. As a doctor, I'm not sure we must all be taking this much balanced diet. If we would have, I don't have noticed my hairline receding, but maybe because of that stress, work stress we have. Okay, maybe because of that happens. Okay, all right. So plate rule: 50% should be vegetables, 20% should be proteins, and 25% should be complex carbs. Okay. Now, one more thing I want to tell over here, which I studied recently in one of the journals. So it is already given in Ayurveda. I'm not saying Ayurveda is completely, this should be disregarded. There are a few good things in there as well. But obviously, everything has to be evidence-based. So I'll just tell you about this study. So what did they do? They checked for, before eating, they ate the salad. Okay. They ate salad. And after that, they went on to the vegetables, then went on the proteins, and then went on to the carbs. Okay. Then the Okay, then the rest of the things. Okay, I'll share the PPT. Entire PPT I will share in the groups. Don't worry. I'll share the link also. Okay, so then they took the carbs, but and in the normal person, first bite we take always is chapati, right? Chapati and sabji and rice खाने से पहले we don't start our meal. So that is the normal diet. Carb, the rice. In some part or some communities, the rice is ate first. Okay, then carbs. But that is no go. Okay, so carbs should be last. So if you eat this, your glucose spikes will be high. If you eat in this manner, there was 30 to 40% reduction in the glucose spikes. नीचे नहीं गया पूरा, but I can say इतना spike हो गया है as compared to this इतना spike हो गया. So always be a little cautious about your glucose spikes. Okay, so this was the diet 40 50 20 30 protein and 25 30 healthy fats. Okay, healthy fats में घी मत खाओ. Okay, ghee. I have seen one doc. I don't know he is doctor or what. Prashant Desai. He is also one influencer. Okay, and there's one more influencer. I don't know his name. Sani, Dr. Sani. So they said कि ghee is healthy. You should eat maximum ghee in the day. But no, please remember, ghee is a saturated fats. If you take more saturated fats, your lipid profile will get damaged in 1 month. The ghee, what we have at our home in gaon mein, in rural area, that's a natural ghee made from the natural curd. But what is made in the uh, private or corporate setup, this is something different. Okay, so this alpha linoleic acid, ALA, and DHA, EPA, the omega-3 fatty acids, तो रहता नहीं है omega वगैरह, but alpha linoleic acid का जो component है, that is very low when it comes to about the um, outside ghee or branded ghee. So better if you take natural ghee, that's also okay. Natural ghee में processing कम रहता है. So the processing कम. Okay, that's why. So I would say the normal amount is almost 5 to 6 gram is okay. That is 2 to 3 tablespoons, not more than that. Any amount of ghee. Okay, so healthy fats you have to take is in the form of the oils, avocado, egg, can take. Okay, homemade is also okay, but again that is made from the right. So coming to the next case about this, let's start case number 6 because we have to cover the session. Right? So 29-year-old woman has HbA1c of 9.2, FBS is 92, postprandial is 138, HbA hemoglobin is 7.9. Her resident wants to start insulin. What should we do? Should we start or not? What do you think? Why no? Why no? Exactly. This is pseudo. We already discussed this case. So when should we start insulin? Insulin should be started. I'll tell you the formula. If patient's FBS is more than 126 persistently, post-angle is more than 200 persistently, if self-monitoring of blood glucose is high, symptoms present. Okay. Okay, symptoms present. Then in this case, you have to start. And again, HbA1c of more than 10. Patient is on the other OHs. And if they're not responding well, then you should start the insulin. Okay. So ये patient में insulin का कोई role नहीं because this is anemia. And what do we do in this patient? We check the fructosamine. Okay. So we check for the fructosamine or glycated albumin, and that's how is the answer. Okay, we already discussed this topic. Now here. So we have a 53-year-old man. HbA1c is 11.4, FBS is 198, ppbs is 289, ACR is 90. Normally it should be 30, okay? 30 to 300 and more than 300 so macroalbuminuria area there. It is normal, okay, less than 30. Then it, around 30 is micro, okay, and then it becomes macro. Okay, micro. So this patient has HbA1c 11.4, FBS, ppbs, weight loss, OED, we have given already for 6 months. What is the primary mistake? Not adding DPP4, not adding SGLT inhibitors, not adding delayed insulin initiation, not adding pioglitazone, not starting statin. Tell he is already on the triple OAD since last 6 months. Now, why we have not already started on insulin? Why waited till HbA1c becomes 11.6? Right? If fasting blood sugar is even just more than 126, I told you to start insulin. This patient has fasting blood sugar of 198. That's not so done. So that's why. Okay. Postprandial was also more than 200. That is 289 in this case. So he should have been started on insulin quite earlier. Okay. So that's the answer to that question. And that's the mistake in this case. All right. Yeah, DPP4 and all are different thing. But when it comes to oral therapy versus insulin therapy, this is what we have to do. Okay. So this patient has got glucotoxicity. Okay. And this is uncontrolled diabetes. Okay, right? So glucotoxicity का cycle कैसा होता है? High glucose, beta cell exhaustion. We already discussed. High glucose, beta cell exhaustion. High glucose, insulin resistance बढ़ जाएगा, will increase. Muscle GLUT4 down regulation will happen. Again, because of hepatic insulin resistance, hepatic glucose will rise up. Then kidney glucose reabsorption occurs. Yes, we start OHA, but if persistently, if it is more than 126, irrespective of starting OHA, then we will start insulin. Okay. So the result for all of this glucotoxic cycle will be A1C keeps on rising despite drugs, and oral antidiabetic drugs escalation is useless because patient is having glucotoxicity. So whenever there's a glucotoxicity, better to hit the insulin itself. Okay, hit with the insulin. Okay, insulin production will go down. Right. So this is the glucotoxicity, what I just spoke. High glucose, beta cell exhaustion. Okay. Insulin resistance increases further. Muscle GLUT4 down regulation. Hepatic glucose output increases. Kidney glucose reabsorption increases. So better A1C keeps on rising despite drugs, and oral anti-diabetes escalation is useless. Okay. So the same thing what I have just explained. Okay. Okay, इतने ही केस है क्या आपके पास? ओके, 7 ही केसेस है. बिकॉज ऑफ सम इश्यूज आई थिंक बाकी के 3 केस नहीं हो पाएंगे. Maybe the PPT is not available with me, but I can tell you verbally the cases. Okay. So next case is, I'll write 1 second. I'll write the case here. Okay. So next case is patient is 58-year-old diabetic patient is there. Okay. 58-year-old diabetic patient. He has creatine of 0.9. Okay. This is the creatine 0.9 creatine. Then EGFR is 92 and ACR is 120. Okay. So doctor is saying the kidneys are normal. What is your interpretation of this patient? Doctor says, his primary doctor says, your kidneys are okay because EGFR is normal. Okay. What do you think? Exactly. Damage is started. Now, this is microalbuminuria, as I already told. If A1, A2, A3 are the 3 stages of albuminuria. Okay. If it is less than 30, that is normal. If it is 30 to 300, it is microalbuminuria. Okay, if it is more than 300, it is the macroalbuminuria. That means kidney damage has already been started. So ACR arises years before creatinine. Okay, and creatinine will rise only after how much? 40 to 50% of the loss of nephron loss. Okay, so this is the logic behind that. Now, how will we manage this patient? So we should manage this patient with the SGLT2 inhibitors. Okay, तो इसमें क्या क्या मिस्टेक किया है उन्होंने creatinine, they focus more on the creatinine than the ACR. They should have focused more on this because ACR is the first marker of the kidney damage and not creatinine. They focused on EGFR, did not focus on ACR. They did not add SGLT2 inhibitors. They did not control blood pressure properly. And no ACE inhibitor ARB started for that patient. So obviously the things has to get worse in this patient. Okay. So this patient was patient with uncontrolled hypertension and ACR. Okay, positive ACR. Okay, so I hope you got this. So please make sure that for what patient, I'll just make one more slide over here, that in what patient we should do DKD screening, annual screening. What all factors we have to check. So Please remember, annual annual screening should always include the urine ACR, that is albumin creatinine ratio, EGFR, BP, fundus, food, lipid. Okay. And treatment for microalbuminuria. What was that? ACE inhibitors. Exactly. ACE inhibitor. First line will be ACE inhibitor. Second will be SGLT2 inhibitors. Okay. Obviously, weight loss and salt low salt Okay. All these things were there. Got it? Coming to the next case, ninth case, we have, I'll draw over here. So we have a 59-year-old man again, okay, with the oral, already on the oral anti-diabetic drug since last 12 years, and suddenly develops the blurred vision, okay, and never had the eye exam till now. People say with the confidence, and they love the fact that they have never visited a hospital. Okay, I don't know why. 59-year-old male, diabetic, OAD since 12 years. Both ACE inhibitors or ARB, both can be given optionally. Okay. It's not like they're only ACE inhibitors. Either way, you can give. If ACE inhibitor related symptoms are there, like angioedema, edema, etc., there, complications are there, then prefer ARB. Again, make sure you're ruling out the hyperkalemia. Okay. It's a big topic. I've covered that in the detailed module. That's why I can't explain anything more. Okay. Yeah. So we have 59-year male, diabetes, OAD, since last 12 years he's taking. Now he has developed the blurred vision. And with confidence, he says, yes, sir, I've never had the eye checkup in my entire life. But what do you think is the problem in this case? I'll just ask you the questions. Is it cataract? Is it glaucoma? Is it diabetic retinopathy? Or is it blurring because of hyperglycemia or vitamin A deficiency? It's the missed diabetic retinopathy. All right. So what happens because of chronic glucose hyperglycemia or chronic hyperglycemia, what happens? There is a capillary basement membrane thickening happening. Okay. So this capillaries in the retina, basement membrane, they get thickens because of more and more glucose. And that causes the microaneurysm. Causes what? Microaneurysm. This microaneurysm ruptures. Okay. And the rupture causes bleed in the brain like this. Aneurysm means what? Thoda sa. Enlargement. Okay. Small vessels may enlargement. Okay. Okay, that is aneurysm. So that aneurysm will rupture and that will cause bleed like that. What is this spot is called as in your eyes? What will this called as? What spots? Suppose exactly cotton wool spots. That's what I was supposed to ask you. Okay, so we have cotton wool, let's say, and we make spots on the building. How does it appear? So that exactly appears like that in red and cotton wool spots. Also, it will cause the hemorrhages. Okay, hemorrhages. And now to heal that, in the last phase or the advanced retinopathy, you will have the neovascularization. So if they ask what is the first finding of diabetic retinopathy, that is microaneurysm. And what is the last phase? That is neovascularization. New vessels are formed. Again, they will rupture and cause complications. Okay. So diabetic retinopathy has the complications. All right. So remember, so what are the stages of retinopathy? First we have is non-proliferative, then proliferative. Okay. First we have NPDR, that is non-proliferative diabetic retinopathy. Then PDR, that is proliferative diabetic retinopathy, and then diabetic macular edema. Okay. So this is proliferative, this is non-proliferative, this is diabetic macular edema. Got it? Now coming to the last question of the day, very important topic, an easy one for you. So we have a 62-year-old man. Okay, now the age of the man has increased. Okay, 62-year-old man coming to us with a numbness of the feet. Okay, numbness of feet. What does that mean, numbness of the feet? That means sensory losses. Okay, and there is a painless ulcer. It's very common scenario. Painless ulcer is there over his big toe. Okay, he ignored it for weeks because there was no pain. So, what explains this? I have four options for you. Yes, diabetic foot, very good. But what explains this? Option number one, sudden trauma. Option number two, neuropathy with loss of protective sensation. Option number three, peripheral vascular disease. Option number four, gout. Option number five, wrong footwear. Exactly. It's a neuropathy with loss of protective sensation. And that's causing this diabetic foot. Okay. So please remember, in diabetic, we have three types of neuropathy: sensory neuropathy, motor neuropathy, and the autonomic neuropathy. Sensory neuropathy means what? Sensation will not be there. कैसे sensation? आ गया वो सिर में. You recall that real झंझनाहट झुंझुनाहट जो भी है मुझे I don't remember that. Okay, so sensory neuropathy, motor neuropathy, and the autonomic neuropathy. So sensory neuropathy, oh, again, that reel just came in my head, but I can't remember and recall all those things. Okay, so that will be sensory neuropathy means no pain will be there. Then motor neuropathy means what? Deformities or joint pain will, or pressure points will be deformed in these patients. And second is dry skin cracks. Okay, somebody is asking me a little intellectual questions that why the damaged blood vessels also cause delayed mood healing. Absolutely, it will cause. The primary cause I want to ask. Okay. Yes. Third, the damaged blood vessels will cause more the gangrene, the peripheral vascular disease, rather than the ulcers. Okay. So the causation of the ulcer is what I asked in this question. All right. So sensory neuropathy, motor neuropathy, and the autonomic neuropathy. Sensory may no sensation, motor may no motor activity, and autonomic may no. There will be no sweat, no blood pressure regulation. This patient will be more prone to the orthostatic hypotension. Okay, so all these things are important. And sometimes in this patient, because of diabetes and because of vascular phenomena, peripheral artery disease will occur, which will again cause the same thing, poor healing, and infection will also occur, which will cause the rapid progression, okay, of the diabetes foot. So the only thing that option left after all of this thing is cut down the foot, okay, or the amputation. So for that, we have the test, which is called as, for checking neuropathy, we have one test that is called as monofilament test, okay, 10G or monofilament test. So what do we do in this? So suppose this is my leg, okay, just imagine this is my leg. I'm very bad at drawing, okay, that's why maybe I've taken medicine, not surgery. All right, so this is my leg, suppose, okay, this is the foot, this is the foot, this is the foot, this is my knee, this is my leg, okay. So this is one filament I have, okay, in my hand. Now I'm checking the test over here, okay. Okay, sorry, ulta ho gaya. One second. So I'm checking the filament test over here. So ये इतना बड़ा filament था, इतना बड़ा था, और अभी ये क्या हो गया, मैंने पैर को लगा दिया ना. So it got folded like this. फिर यहाँ पे आ गए. तो ऐसे करके मुझे 10 पॉइंट पे चेक करना है पैर में. I have to check at 10 different points in the foot. That is my 10G monofilament test. And if it is less than 4, okay, 4 to 6, then my patient has the neuropathy. Out of 10, if only 4 to 6, if less than 4 to 6, he can identify, then it's a peripheral neuropathy in your patient. Okay, so please make sure. Then in this patient, what advice we will give to the person? We will ask them to never walk barefoot, check foot daily, moisturize soles, sorry, avoid deep nail cutting, and proper footwear. Okay, so ये footwear का advice दे रहा है उसको. Daily you have to ask them to check their foot. Never ask them to walk barefoot. Okay, they can walk, but not with the barefoot. There are special diabetes foods are also available, which you can try. Moisturize soles properly, avoid deep nail cutting, and proper footwear has to be given. Okay, so these were the top 10 mistakes which I feel are important in diabetes that you should know. First one was LADA. Second one was HbA1c वाला था, false HbA1c, HbA1c दो बार आया. Third was wrong drug, giving glimepiride, causing weight gain. Better to give other drugs, okay? Uh, SGL2 or GLP-1 or even insulin. Then exercise errors. HIIT is not for all diabetic patients. Nutrition errors. Don't follow crash diets. Okay, no, just don't say no to carbs directly right away. Okay. Then we discuss the insulin delay. Don't delay insulin treatment. Start insulin. Don't worry about the insulin. You can start. Insulin is anyway, you can remove. Okay, it's very short acting, nah? 6 to 8 hours. Then you can remove the insulin. I mean, if at all somebody is so worried about it, okay, it will not cause long-term side effects. Okay, so start insulin right away. Then complication screening we discussed, kidney disease we discussed, eye disease we discussed, and the last was the foot one, neuropathy. Okay, so this was the comprehensive session on the diabetes, which I want you all to remember. Okay, and want all of you to be really, really perfect when it comes to diabetes care. I'm not here to advertise anything, but if you are interested for our ACPD course, ACPD, that is Advanced Certificate in Practical Diabetology, this is just one session of the ACPD. Okay, we have discussed diabetes in so much of detail in that. Okay, so if you want to join, I will share the link in the group. You can just check that. So there won't be any issue with this. Okay. All right. Any issues? So diabetic ketoacidosis and all, it's an emergency, na? That will be there in emergency. The fees is for that right now it's 2399. It's the most affordable diabetes fellowship. We have diabetes. We have partnered with the United Diabetes Forum (UDF). Okay, it's a very good. Even AD. I'm a ADA certified doctor, ADA certified diabetologist. Okay, so it will be good for your thing. DKN and all. Emergency also we are conducting. Emergency also we are conducting. Soon we'll be launching that. Okay. So with this, I would just like to tell few things to all of you. Please remember. Okay. This screen share I will be stopping now. Okay. So please remember that in life, you should be very clear with what you want. I mean, there is one concept called as lotus theory. Okay. So that's low. What is that lotus theory? It tells us that you can achieve anything you want, but you have to focus one thing at a time. So if you are preparing for any exam, just focus on that. If you're working in practice, focus on that. But it doesn't mean that you should ignore completely rest of the things. You have to work for that direction. Yes. What is the question? Can we get ADA certificate? No, I mean, like, not all can get. Okay. I will give you the adrenaline wala. Adrenaline and UDF partnership. We will give you completion certificate. Okay. My question is to you is Degludec having sorry, this is so big question. We'll take it later. You just WhatsApp me. Insulin treatment stopped after starting. Insulin treatment can be stopped after starting if the patient's response is good, but it takes certain amount of time. If patient has lost a good amount of weight, around 10 to 15%, then. For type 1 diabetes, yes, it is available, CGM. It is advisable for type 1 only. Okay. What duration can insulin stop? So it depends on the patient's response, doctor. Okay. It's not like that after 10 days, 15 days. It's not an antibiotic course. Okay. वो भी अपन 2 दिन में बंद करते हैं. So it depends on the patient's response that how his glucose is responding. Is he working properly? Are his spikes of glucose is in control? Then for LADA investigation, you do antibody testing. No, I will share the PPT also. Okay. So there's one more thing I would like to tell you at the end of the discussion, apart from the lotus, that is focus should be really, really, focus is obviously really important in these days because the social media is all about distraction these days, right? So you have to work like an artist and train like an athlete. My guide used to say, and I've read it in one book. That duality, the theory of duality. You should be absolutely mastered in whatever you do. Today I spoke with Sumer Sethi sir. If you know him, he's a founder of DAMS. He was also mentioning the same thing in his talk. That tell me, in what thing in your life you will give 100%? For what activity you will give 100%? Tell me, anybody? Yes, please. Don't ask clinical questions. I'll answer that later. First, answer what I'm asking. You will give 100% to practice. Somebody says sleeping. Somebody says yourself. Okay. Kids, very important. Helping others. Okay, good. Patience, still figuring out. I am mother 100% to my kid. Sing patient. Mental health, very important. Family. So this duality means what? Duality means give 100% to everything. Give 100% to everything. And most of the time, your 20% effort means your 100% of justice to that particular thing. For example, if I want to study diabetes, if one day in 365 days I study for diabetes, I study diabetes for entire day. I read 4 or 5 books, just go through the theory and all. I am master than more other people. So that is the theory. Whenever you're doing certain activity, give your 100%. You're 100% with the kids, you love them. You're 100% with the studies. You're 100% with the clinic. You're 100% with the patient person. Okay, so please believe in this duality. And lastly, before ending the session, I know I'm not giving much of philosophy, but what I feel is always it's important to share what I know. So I was speaking with Dr. Ravi. He's in the US. He's an internal medicine specialist. Dr. Ravi Godse. I will answer. I will answer on my reels. Okay, no issues. So yeah, what was the question? Yeah, I asked him. You DM me, beta. Okay, you DM me. Yeah, Dr. Ravi Godse. Exactly. Dr. Ravi Godse. Okay, I was speaking to him about the empathy and the crimes against doctor. So I just want to give that last message to all of you. Even if it might be your 20th patient or 100th patient of the day, for that 100th patient, you are the first one. Always talk in that way to the patient. Okay, ask him, take the history, make proper analysis of his complaint, listen to this patient. I know you are all suffering, you are all overworked, but when it comes to patient care, you have taken an oath for that. Okay. If you do that, I think majority of the, not majority, but at least 10% violence against doctor might go down. Okay. So that's the small message I want to give at the end. I hope you like the session. I will take AI session also. One more webinar I'll take. Okay. For endocrine, come to my hospital. Not promoting. You can go to KM. KM has one of the best endocrinology institute. Lilavati is good. Uh, AIMS, all the AIMS are good. Okay, you can go to any AIMS. Okay, so thank you so much, guys. एक photo ले लेते हैं हम लोग. I request you to turn on your camera if you can. I think, but wait a second. I'll allow everybody to share camera. Allow participants to share camera. Where is this setting? I practice at South Bombay. The clinic name is True Vision Clinic. I'm working over there. Working in the sense I've rented that place. That's in near Opera House, South Bombay. You can message me. I'll share. Okay. Okay. Great. You can WhatsApp me, please. I'll share my number at the end. You can just write down all of you. 75, sorry, 92843. That's my personal number. I've asked all of you to unmute. I'm not sure will you be able to share the screen or not. I think no. This is webinar, na? That's why maybe you are not allowed to share the screen. Ah, 92843 73002. Anyways, so you can take picture. Anyways, I'll just disconnect it from here. Okay. You can take picture and share this with me, guys. 92843 73002. Okay. 92843 73002. That's the 73002 at the end. Two. I'll put it in the chat section. Please don't worry. Even I wanted to take picture, but this is webinar, na? So that's why I think I'm not able to take. 1 second. If you have time, please wait for 1 second. I'll just see if I can message him to allow participants to show their cameras. You can only raise the hands, I guess. Anyways, no issues. All right. Yeah, no options for camera. I don't know why. Okay, I'm really sorry for that. But the meeting has a limit of 100 now. That's why maybe in webinar we had like more than 500, around 500 people we could have taken. So you just take a photo. Maybe you can tag me. I'll reshare that. If you like the session, tell me your honest opinion also on that story. I'll be sharing. Yeah, yeah. I'll share the this thing. Sorry. Okay. Thank you. Anyways, I hope you liked. We'll take. Okay. Yeah. Okay. Thank you. Thank you so much, guys. Bye bye. Please take care. Thank you. Thank you so much, guys. So sweet of you all. Sure. YouTube, I'll share. I'll share the story on my Instagram. And if you are on any of the group, I'll share. Thank you, guys. Thank you so much. Bye bye. I'll take some medicines now. Good night.